All righty, we are going to get started here. I want to thank everybody for coming today. This is everything you want to know about COVID and the COVID vaccine. My name is Dr. Valda Crowder. People call me Dr. V. I've been an emergency physician now for about 30 years. And I've put this together so that we can keep ourselves abreast of the science as it actually changes, and can actually sort of adjust our plans for our families and communities. The documents and the source documents for this can be found on AskDrV.us. There's also always an invite to this presentation on that website. And then you can also follow me on AskDR_V. All right, so let's get started. So it's going to be a 10 or 15 minute presentation around the slides. Today it might be a little bit closer to 20 minutes. There's a lot of stuff around the vaccines. And then we'll do Q&A for the rest of the time. Normally we end right at about 9 o'clock. During the presentation, everyone is in listen mode. If you have a question, you can type it into the chat or you can type it into the Q&A as the presentation is going on. So don't think like you have to actually remember what the question is. You can begin typing it in right away. All right, the intention of this webinar is to keep participants informed with COVID-19 science that will help them and their families stay healthy during the pandemic. The outcome is that you will leave this webinar motivated to create or improve whatever your action plan is for yourself and your family. Now, some people may be responsible for creating or improving an action plan for a broader community, like a church, or maybe their clinic, or a homeowners association, or a business, or a union, or a school, whatever it may happen to be. This is where we are right now. Globally, there's been about 98 million cases, roughly. The United States is 4% of the world population, but we are 25% of the worldwide cases. Similarly, around deaths, there are about 2 million deaths, and we are also about 25% of those as well. When you look at how we've done against other countries, UK, Germany, Canada, Mexico, this was as of about mid-December or so. We have uniquely not done well. I tell people COVID is everywhere, even in the San Diego Zoo. Now, most other animals other than human beings actually have antibodies against COVID-19, and they actually don't get sick with it. So even though these gorillas were positive, they did not get sick. If we look at vaccines, there's been about 36 million vaccines distributed, and roughly about 16 million of those vaccines have actually been administered. So I want to talk a little bit about a collapsing healthcare system and what that looks like, because we're seeing this in some states, particularly in California. And I want people to be aware, so they do end up in the hospital with a family member, they know the signs of these things. So one is you start using unusual spaces for hospital beds. So in Los Angeles, they're using the chapel and the gift shop to actually create beds. You also have facilities that are running out of PPE, oxygen, and they may be stretched staff-wise, particularly nursing staff. Also, what happens sometimes is ambulance diversions. You would normally go to this hospital that's closer to your home, and instead they take you to a hospital that's way across town. Or they may come to your house, check your pulse ox and check your oxygenation, and say that they cannot transport you to the hospital because they have to transport someone sicker. If that occurs, you can always get in your car and still go to the emergency department. Other things that you may see is long wait times in the emergency department to get upstairs to a bed. In California and some other states, they've changed the guidelines. So now the EMS can pronounce patients in the field and they don't have to transport them to the emergency department. And you also have in hospitals across the country, ethics boards that have formed that are setting standards for withdrawing care. And you may have, they basically set standards that allow the physicians and the nursing staff to withdraw care if they actually do not have enough beds or enough ventilators or anything that may be running low. All right, just quickly, I'm not flying, and people always want to know why, and I love this slide because basically, if you look at what the airlines are doing, Masks are available at most of them, but not Frontier, Spirit, and Sun Country. All of them require masks. Not all the airlines are cleaning before every flight. Several airlines are not. And also, if you look right now, Delta is the only airlines that has said and promised not to sell the middle seat until March. So if you fly anybody other than Delta, you may be squeezed in and have a full flight. We're now requiring international travelers to show proof to the US before leaving that they've had a negative test. It must be 72 hours. Other countries are concerned about their citizens coming back from the US infected. I talked a little bit about contract tracing and in a previous webinar, and that's what we are not doing in the United States, particularly amongst flights. So I just wanted to show this. Since January 7th in Canada, there's been a total of 70 flights that have had somebody COVID positive despite their COVID testing required before boarding. 70 flights have had somebody who was COVID positive. Now, in Canada, if you have a single passenger on board, in a couple of these flights, they've had more than one passenger on board who was COVID positive. The airlines contact you and they tell you that you've been potentially exposed, and they have everyone on the flight actually get COVID testing. We are not doing this in the United States. So this is another reason why I'm not flying. All right. As I always say, respect COVID-19 is highly contagious. That is calculated by the amount of time it takes to actually catch COVID. If you're infected, if you're exposed to somebody who is infected, it can take as little as 45 seconds. If you talk about the UK variant and some of the variants, mutations that they're saying now are more infectious, that timeline can be even lower. If you look at the number of people, the percentage of people that would get it if they come into contact with it is about 60 to 80%. That's different from the flu, which is about 30 to 40%. Now, as we know, it's both droplet and airborne. Initially, we thought it was only droplet, and that's how come it was the initial recommendation was to stay only 3 feet from people, and now the recommendation is to stay 6 feet or more. So if this is what it actually looks like, if this person was COVID positive and he was talking or singing or coughing or whatever, the red dots are the droplets and the gray is the airborne. So the red droplets are bigger and they actually drop very close within 3 feet of the person, and the airborne particles can go further. Now, how do I know if my family or I have COVID? Basically, 3 types of testing: PCR, antigen, and CAT scan. PCR testing is the gold standard. That is the swab of your nose that's extremely uncomfortable. It'll make you blink a couple times and maybe even tear up. It's most accurate 8 days after exposure. It can be inaccurate if it's administered too soon or too late. The antigen test is the rapid test. This test is not as reliable. So 30% of the time, it will tell you that you have a negative test when you really have COVID-19. That's really important. 30% of the time, it tells you you're negative when you really have it. So if you have a negative test, you probably need another one. In the hospital, we make people get 2 separated by 24 hours before we determine that they're actually negative. You can also diagnose by CAT scan. This is a little difficult to see. I'm going to blow it up just a little bit. And this just shows what a CAT scan is. Very minor, but it's sort of white opacifications on both sides in the lungs that normally are not there. You can really see it on the one to the right of the yellow marks. So anyhow, that is what it looks like when someone has viral pneumonia. So it's ground glass opacifications. Oh, hold on. All right. Now, the other thing, which is really exciting, is that dogs that COVID-19 has an odor, and dogs are actually more accurate than the PCR or the antigen test in actually smelling and detecting COVID-19, which can be very useful in airports. There's also a home test. You can purchase it now on Amazon. You do have to send it into the lab. It is a PCR test. I just show it here. It is $110, and you can send it on into the lab and take your test. All right, so let's talk about the symptoms, because the symptoms actually determine how sick you're going to get. There's basically 6 different clusters of symptoms. Clusters 1, 2, and 3 are the ones where you can normally have COVID-19 and do fine at home. So cluster 1 is flu-like with a fever. Cluster 2 is flu-like with a fever. And cluster 3 is basically almost like a stomach flu. You get nausea, vomiting, diarrhea. So those 3 clusters actually often do not have to come into the hospital. Now, cluster 4, 5, and 6 are usually the ones that actually have to get admitted. They have to sometimes go to the ICU, and these are also the patients that sometimes die. And that is when you get sort of fatigue is cluster 4, cluster 5 is confusion, and cluster 6 is where you sort of get almost all of the symptoms all together. You get abdominal and respiratory symptoms all together. I show this chart just to show that, you know, there's no set of symptoms that occur all the time with COVID-19. So about 22% of the people do not get a fever. About 43% of the people do not get a cough. You even have about 80%, 75% of the people that do not get difficulty breathing. So if you look at this, it really shows you that it really can present a lot of different ways in different people. A lot of people ask me about the flu. The flu in a year has infected anywhere from 30 to 40 million people, but only has had, in the worst year, 60 or 70,000 deaths or so. Conversely, COVID-19 has infected about 16 million people. I have to update these numbers because we're now at 408,000 deaths. And we're now up to 20 million people. So I have to update this slide. So as you can see, it's just a deadlier disease, right? So 408 people in about 10 or 11 months. It hasn't even been a full year yet. The other thing about COVID-19 is COVID-19, we've had to shut down all elective procedures. We've never had to do that for the flu. Almost 100% of the beds in a lot of the hospitals in the ICU are COVID patients. COVID is a multi-system disease. It causes renal failure. It causes inflammation of the heart. It causes strokes. It causes blood clots. People have to get amputations. You don't see all of that with the flu. We also have patients who have required ECMO, which means, and I'll go over that a little bit later, but that's people who you cannot ventilate even on a ventilator. And we've had some folks afterwards that have had to get a double lung transplant. Now, what do you need to do if you think you're COVID-19? Now, some of these things I think it's important to have in your house ahead of time. One is a pulse ox. Those are $20 to $30. The picture of it is over there to the right. The top number is the most important number. That is your level of oxygenation. On the picture to the right, that says 97%. You want that to be 95 or higher if you're a healthy person and you're a non-smoker and you're, anywhere between, 12 and 65 years old. Zinc and vitamin D3 are also very important. I have the dosages here. I do recommend that people take, you can take like a zinc and magnesium. Sometimes they have zinc, magnesium tablet, and then they have a vitamin D3 or a vitamin D tablet. I prefer that you take those as opposed to a multivitamin, because sometimes with a multivitamin, you don't get the amounts of the zinc and the D3 that you actually need. The other thing is that you want to have a bathroom that's only used by you, and you want to have your cell phone with you charged. So if you need some help, you're not going to call a family member. You're going to call 911. You want to leave some food at your family members, if they're there, will leave some food at a closed door. And you want to open up the windows to your house. I tell people this is the time, even though you have to put on the heat, open up the windows, let some of that heat out, because you will also let some of the COVID out. And then some people have installed HEPA filters or have air filtration going on in their home, which is also very important. All right, let's talk a little bit about how to advocate for a family or member or a friend that is hospitalized. So it's important that one, you appoint a family representative that will talk regularly with the physician and nursing staff. And then that one person reports back to the family. So that way there's not multiple family members calling for one patient. So best to appoint a family representative. That family representative should clearly know what is the name of the nurse, which may change daily, and what is the name of the attending doctor. Now, the most important thing in that sentence is attending doctor, because you will have a lot of doctors if you're in the hospital with COVID. There may be residents, there may be fellows, there may be specialists. The attending physician, and the word attending is very important. The attending physician is the person that is responsible for the total coordination of your care. Now, who are the specialists and have they been consulted and what are their names? So if they say, well, we consulted a cardiologist, great. You want to come back and you want to know, not only did my family member see a cardiologist, but they saw Dr. Smith. So you want to actually know the name of the cardiologist or the practice group. Now, set up a time to regularly call. It's good to tell the nurses, I'm going to call every day at 11 o'clock, because then they will remember every day at 11 o'clock that you're going to call, and at 9:30, 10 o'clock, they'll put together all the information they need so they're ready to actually have a family call. I remind people that at most hospitals, shift change occurs at 7 or 8 a.m. So a regular call during that time period usually would not work. Now, you also want to make sure that the medical staff is aware of what was this person like before they got sick. Were they working? Were they driving? Were they living without assistance? Were they walking without assistance? Were they exercising 3 times a week? Were they playing tennis? When someone is laying in the hospital bed, they often don't look like they used to look, and you don't know, who really had a very active lifestyle, because that will make a difference in what resources they're given. Make sure to know each other's wishes. Does your family member want to be put on a ventilator? Do they want to be resuscitated? Do they want things like ECMO? There also could be things that someone does not want done for religious reasons. A typical example would be someone who maybe is a Jehovah's Witness and doesn't want blood transfusions. So all of those things are really, really important, and they're important to actually communicate to the staff that's taking care of your family member. Let's talk about a couple other things. One is most insurance companies actually limit hospitalizations to 30 days. So be aware of the 30-day push. And it is an arbitrary cutoff for some insurers. May or may not be so for your insurer. You want to know what are the limits. But if you suddenly see near 20 to 25 days, the hospital staff is going to put a tracheostomy in, and they're going to send the person to a vent-dependent nursing home. You really want to make sure that you've spoken with the doctors and the specialists and make sure that your family member is stable enough to be transferred or discharged. You can always ask for a second opinion, right? And so, but if they're discharged too often, sometimes they can actually have to return or don't do well in the particular setting that they are sent to. Physical and mental rehabilitation, you want to make sure that you're asking for it, make sure you're getting enough, make sure you know how to actually replicate it at home. At discharge, be clear about home health care services and what's being provided. Who's coming? How frequently are they coming? When do they start? They may say, well, we have somebody, they're going to come twice a week, and then you find out they're not going to start for 2 weeks. What equipment do you need? Do you have it at home already? Make sure that you have everything you need at home before taking a family member home, and that you have all of the equipment and all of the services. All right, now let's talk about COVID-19 and the treatment of it. We've talked a little bit about oxygenation. We've talked about vitamin D and zinc. Let's talk about all the other things. So the first thing is famotidine, which is Pepcid AC. You can have this at home. This is actually associated with lower hospital deaths and lower combined deaths and intubation. And basically what this does is it blocks the inflammation. COVID-19 is primarily a multi-system inflammation disease. Dexamethasone is a steroid that can also be used. That will be used in the hospital. That lowers your 28-day death rate. Remdesivir was used initially. It's not used as much anymore. It really has questionable benefit. Some people say possibly it may get you off the ventilator a day or two earlier, but we haven't really seen any real increase in life expectancy because of it. Now, the antibodies. This is really, really, really important. The antibodies are made by two companies. One is made by Regeneron, and the other one is made by Eli Lilly. But basically, these are antibodies that come from a human that has recovered from COVID-19 and antibodies from a mouse engineered to have a human-like immune system. The antibodies bind to the region of the main surface spike protein and actually make sure that the virus does not attach to the receptor of the cell. These antibodies are very, very important. Eli Lilly's was approved in November 10th. So it's been around now for about 2 or 3 months. This decreases hospitalization by 70%. So you are 70% less likely to have to go to the hospital if you actually get the antibodies. Where are they given? They're given at infusion centers. So some emergency departments have infusion centers, some clinics have infusion centers. You kind of have to call and find out. But I wanted to show, this is how they determine who actually gets it. And I want to actually make sure everybody knows about this. If you're over 65, you get it. So if you look at the N there over to the right, anybody over 65 is eligible. If you're 12 to 65, it depends upon whether or not you have kidney disease, diabetes, if you have some immunosuppressive disease, but most importantly is BMI greater than 35. So a lot of people don't realize how significant being overweight is in COVID-19. And you don't have to be a lot overweight, right? So a BMI of 35 might be a woman that is, you know, maybe 170, 175 pounds and they're 5'4" or 5'5". A BMI of over 35 in a man might be a man that's maybe 5'10", 5'11", and over 200 pounds, right? So it's really, really important. That makes you eligible, and you need to get the antibodies. The antibodies have to be given within 10 days. After 10 days, they do not work. So it is very important that if you get diagnosed with COVID and if you're over 65, that you begin to actually, and you begin to have symptoms, that you actually begin to go and get the antibodies. The infusion takes a couple hours, and then you go home. I'm going to talk real quickly about ECMO. ECMO stands for extracorporeal membrane oxygenation, also known as some people call it a heart and lung machine, but it is where you actually get your blood is taken out of your system, and it is actually oxygenated outside and then actually put back into your system, right? And this is saved for people who are younger and who have COVID that is so serious that we cannot ventilate them on a ventilator. So what happens is with COVID-19, your lungs almost get brittle. And so you actually can't move air in and out of their lungs. And this is, one of the last heroic things that's done at some facilities. A lot of hospitals in the United States do not have this. You have to be at a major medical center to actually have access to this as a treatment. A lot of people have asked me about ivermectin. So this was a study that was done in Chest Magazine about ivermectin being associated with a lower mortality rate. This was a descriptive study. So it's one of the earlier ones that actually came out. It was published in January. There's different treatment protocols now that you're seeing come out that people are actually looking at. I'm just going to show you guys some of them. This one is called Math Plus. This has the steroid, which is methylprednisolone. It has the vitamin D and the zinc and the famotidine that we talked about, but it also has magnesium, melatonin, thiamine, heparin, and vitamin C. This one has actually been shown to decrease mortality by 75%. This is another one currently being studied. This is iMask Plus, ivermectin. Again, you see the vitamin D and the zinc, so that is consistent. You also see melatonin, and it has quercetin, which is a plant-based flavonoid, which you can find in green tea and capers. And this one also has aspirin. The results of this are pending. This is just something that is currently being studied, for outpatient treatment. You can catch COVID-19 twice. The lady on the left was 102 years old, and she actually lived through the 1918 flu and also caught coronavirus twice. The 18-year-old on the right-hand side, he actually battled COVID-19 twice, and he passed the second time. So it just goes to show you that this disease really acts differently in a lot of different people. We found some things that make a difference around blood type, obviously body mass index. There's just all sorts of things that make a difference for different folks. UK did a study, and they found that basically after you've had an infection, that you have immunity for 5 months. So the people who were thinking they were going to go to a COVID party and then get some sort of lifelong immunity, that's just not so. And it's kind of silly to catch this disease just to have immunity for 5 months. It makes no sense. All right, so let's talk about the vaccines and the vaccine trials. So COVID-19 is a viral RNA. It's inside of a fatty coating. Inside that fatty coating, on the outside of the fatty coating, is spike proteins. The spike protein binds to the receptor protein, and then it actually enters into the cell. So when they say that we have variants that make this disease more transmissible, what happens is it binds quicker to that receptor. That spike protein binds faster, and it moves into the cell faster, right? Then once it gets into the cell, then RNA tells the ribosomes to start printing and copying everything. So it copies the virus, it copies the spike protein, it copies the fatty outer laying. Everything gets copied and replicated, creates a whole new virus, goes out of the cell, and goes and infects another cell. And it keeps doing that over and over again. And that is how COVID-19 replicates in our bodies. So what is RNA? There's a lot of different types of RNA, but the one that we're actually concerned about is messenger RNA. And messenger RNA actually transfers genetic information from genes to ribosomes and basically tells the ribosomes, copy proteins. Make a copy of this, make a copy of that. It's like turning on a copying machine, right? So these vaccines, these two that are approved right now, are messenger RNA vaccines. Now, a lot of people ask me, this is a new technology. It's not that new. So messenger RNA is something that's been studied since the 70s. What I'm going to do next week is actually show you all the woman who actually started studying messenger RNA. When she first started studying it, everybody thought she was crazy. But it has been used for oncology, for cancer treatments. So what's new is actually using messenger RNA for vaccines. So the messenger RNA tells the body to create the spike protein of COVID-19. Then once you get vaccinated, your body will create that spike protein. Your body recognizes it as foreign. You develop antibodies, you attack the spike protein, and you kill it. So because you're only making the spike protein, you're not getting the actual virus. You're just getting the spike protein. So when your body sees COVID-19 in the community for real, it recognizes the spike protein and it begins to kill it. Johnson & Johnson has a vaccine coming out, and you'll hear a lot more about this one in the next 2 to 3 weeks. So be prepared to hear about this one. This one uses a viral vector approach. So what it does is it takes an adenovirus, which is a common cold virus, and it connects it with some genetic material from the COVID-19. The combination is rendered harmless, but it teaches your body to generate antibodies that then attack the spike protein. So it renders COVID-19 harmless when you actually come in contact with it in the community. Let's talk a little bit about all the various things. I'm going to actually add, I know from our community, I got asked to provide some of the actual data. So that will be coming on Tuesday. So you can see how many people did they actually give the vaccine to and what actually happened. But both Pfizer and Moderna are 2 doses. One is 21 days apart, the other one's 28 days apart. They're roughly about the same amount of effectiveness, 92 to 95%. They both can be associated with fatigue, soreness, etc. The Pfizer has to actually be kept in liquid nitrogen. Moderna actually can be kept in a regular freezer. Both of these cannot be refrozen. So that's why you will see sometimes where people will have CVS and whoever's in public health departments will have lists of people that they will call if they happen to have extra doses at the end of a vaccination period. They don't want to throw it away. Now, there was a whole framework for how do you equitably allocate the vaccine, 1A, 1B, 2, et cetera. That has actually been X'd out. So Health and Human Services Director last week said just vaccinate everybody over 65 and just get a vaccine in everybody over 65. So most states are adopting that. Some states are still going with this framework, but a lot of states are trying to just open it up to anybody that's over 65. When you actually get vaccinated, you will still need to wear a mask. This is very, very, very important. 2 weeks after you get vaccinated, you might have 20 to 30% antibodies. A month after being vaccinated, you might have 60 to 70% antibodies. After you get the booster shot, the second shot, it will be 3 to 4 weeks before you get to the 92 to 95 effectiveness. And even then, after you are at the 92 to 95% effectiveness, there is still concern about whether or not someone can still transmit the COVID-19, even though they don't get sick from it. And that is currently being studied. So what we're going to hear about coming up is going to be Johnson & Johnson. AskDrV is also near the end of their phase 3, and Novavax just recently initiated phase 3. Howard University actually is a Novavax site for those of you guys from Washington, D.C. Let's talk about the mutations. We in the United States do not do a very good job of genomic surveillance. So we have very limited information on how much of any particular mutation is in our community. So I'm not going to be able to give you that much information on that, but I'm going to actually tell you about the variants. The UK variant is the one that you hear the most about. There is a small amount of physical alteration on the spike protein, but that we think will be the primary strain by March. It spreads about 70% more efficiently. Then there's a South African variant. This one is actually concerning because this actually has a large amount of alteration on the spike protein, which makes it more likely that it may escape immunization or even an people who have immunity related to having had COVID-19 previously. This is a common strain now in South Africa and Zambia. It also seems to be more dangerous to children. There's a Brazilian variant with increased transmission and increased association with reinfection. And then it looks like there is some variant in California. And we're not sure if that's why California is having a particularly hard time, but there is some variant. And for each of these variants, they have an official name, and the official name are the numbers and the letters to the left. So this was really important. This actually came out today. So this is hot off the press. And this basically says that the Pfizer vaccine is actually effective against B.1.1.17, which is the UK variant. So they have tested it against that variant and determined that the Pfizer vaccine is effective against that particular variant. The World Health Organization team on January 14th, about a week ago, large team traveled to Wuhan, China, to investigate the origins of the pandemic. This was a group of veterinarians, epidemiologists, infectious disease physicians, large group. And so this team, when this team works, I think that we will actually begin to see, and get information on what was the actual origin of this COVID-19 global pandemic. The World Health Chief, General Tedros, warned that COVID-19 will not be the last pandemic. It's important for us as countries all over the world to really prepare on how to really work together when something like this happens. How to get your vaccine. I'm telling a lot of people, go to your county public health department, not physically, but online. So if you Google your county public health department and you just put in COVID vaccine into the search bar, then it will give you instructions to schedule your vaccine. In some situations, it will tell you that we don't have any appointments, but we're going to have appointments starting Monday at 9 a.m. If it says that, then Monday at 9 a.m., you've really got to get on at 9 a.m. In Washington, D.C., there were 1,486 vaccinations that were available. They were gone in 20 minutes. So this is really, really something that you have to stay on top of. So get that done. All righty, we are going to go to Q&A.